Hello everybody, great to have you back in. Welcome into Sono 1420 Distillery in South Norwalk, Connecticut. That's 19 Day Street. If you're in the neighborhood in South Norwalk, come hang out with us on Saturday night. Little anniversary party, 2-year anniversary, all the way through 8 o'clock and probably later, but come hang out with us, great time and even better drinks. I'm Dave Briggs, former CNN, NBC Sports, Fox News anchor. Connecting Connecticut once again, and I want to hear from you. Don't want this just to be an interview, but a conversation amongst all of us. So please send me a message. Let me know who you'd like to see interviewed in this space at Dave Briggs TV, or let me know if you have questions for current guests, because I know everybody's got questions for today's guest. Who doesn't? He's become arguably the most respected voice on COVID in this country. With all due respect to Anthony Fauci, this is the guy I listen to, and my best friend, and he said, that's the only guy I listen to when it comes to COVID, a real voice of reason. And we're lucky to have him as a Westport, Connecticut guy. Dr. Scott Gottlieb, good to see you, sir.
Hi, how are you? Still getting
Did you find a stand for the phone? That was the big question we had.
I'm still getting the angle right. How's this?
That's fantastic. And is this your first Instagram Live? Did you nail it on your first shot?
This is my first Instagram Live, yes. That's why I don't have it set up right.
Bravo, sir. We could just do a weekly one now that you got it figured out, because you're not on national television enough. It's great to see you, Scott. You have become, as I just said, I don't know if you heard me, several texts as soon as we announced the interview said, he's the only guy I listen to when it comes to COVID. That's an honor, but that's a heck of a burden and responsibility, isn't it?
I appreciate that. I need to be make sure that what I say is careful and factual each week.
Well, I think you stick to the science and you stay out of the politics, which is remarkable considering everyone who's worked for the Trump administration gets sucked into that void of the cable news mud wrestling political mess. You have stayed out of it. How have you accomplished that?
Well, look, first of all, I wasn't in the administration when this struck. Early on, I was raising a lot of concerns about what I was seeing back in January. Probably made my first phone call to the White House that I remember about mid-January. It was Martin Luther King Day weekend, to air some concerns about the news that was coming out of Wuhan at the time. There were some people who were uncomfortable with what I was saying, felt like I was being, I had some people tell me that I was being alarmist at the time, but, stuck with it in terms of just trying to communicate what I was seeing and some of the concerns I had. I remember the first phone call I made was on January, I think it was the 14th. It was that Saturday of Martin Luther King Day weekend. So it was the holiday. And it was the day that the number of cases in Wuhan had quadrupled from about 50 to 200. And all the reports coming out of Wuhan were that the 200 people had severe pneumonia. So it's very unusual that a respiratory virus would only present with severe pneumonia. So it was a real indication that what they were seeing there and what they were reporting, which they were underreporting, was just the tip of the iceberg. And that really raised a lot of concerns among me, and I know among a lot of other people who were looking at that.
Do you ever look back and wonder if you could have done a lot more good within the administration as the FDA commissioner, or are you happy that your role informing the public on national TV virtually every day, have you done more from outside?
Look, I regret not being there. I regret not being there with my colleagues who were struggling to try to respond to this. The one thing that was a frustration early was the lack of diagnostic testing. If you go back and look at a lot of the articles that I wrote in January and February, was about the fact that we had failed to deploy a diagnostic test. And a lot of the officials at the time were looking to CDC to deploy that test and relying on the CDC test. And CDC obviously botched the rollout of that test. But even if CDC had been successful at getting a test available and rolling it out to the public health labs, which was really the game plan that they were working off of, there still wouldn't have been enough testing quickly enough. What needed to happen was we needed to get the commercial labs into the game early, LabCorp, Quest. We also needed to create a pathway for the academic labs, the reference labs, the high complexity labs to get a test out. The hospitals, for example, they operate high complexity labs. They know how to develop what's called laboratory developed tests. And so, you know, if I was at FDA at the time, I think I would have pushed harder on that. And I was talking to folks in the administration at the time, urging them to try to get the labs in the game. Our big mistake early on really was not having a test. And what happened was we ended up getting seeded with a lot of infection and we didn't even know it. And so by the time we really figured out the scope of the epidemic in the United States, it was too late to use what we call case-based interventions, basically the ability to test people and track them and trace them and get people into isolation and quarantine as a way to prevent spread. At that point, we were forced to adopt mitigation. And the other thing was that because we didn't have testing in place, we didn't know where the virus wasn't. We knew some places where it was. We knew the New York region had a dense epidemic, but we didn't know where it wasn't. And so when we adopted the mitigation, the stay-at-home orders, we adopted them nationally. But we didn't need to. Did Bozeman, Montana, and Houston need to lock down and shut down back in last spring? No, they probably didn't. They didn't have a lot of infection. They probably could have used case-based measures, tracking and tracing and testing people as a way to control the spread. But we didn't know that the virus wasn't there. And then unfortunately, when it did eventually come to those parts of the country, a lot of the people who lived there said, look, we've already done this. We did it in the spring. You told us to. We didn't need to. And we're not going to do it again. And so, that's initial mistake of not having a deployable test. A lot of our other public health real tragedies flowed from that.
I don't know how many people you get to hear from, Doctor, but the comments coming in right now, thank you for being a voice of reason through all this. Mr. Gottlieb is the one I trust when it comes to COVID. Thank you for your hard work during this crisis. You are appreciated. You don't hear that often today, Doc, so it must mean a lot. I mean, this is not a time when people are thanking people for their service on television. You do a great job on CBS and on CNBC as well. Let me kind of get a state of the state where you think we are in this COVID mess right now. And we'll get to locally, hyper-locally in Westport, but nationally, where do you think we are?
Look, I think things look very good right now around the country. Obviously, there's still a lot of infection. There's still far too many people getting infected. We still have people dying of COVID and about 40,000 hospitalizations. But I think things are going to start to improve very quickly. When we've seen this virus sort of collapse before, we've seen it collapse very quickly. If you look at Michigan right now, the trend line in Michigan, cases are coming straight down in Michigan. Just like they went straight up, they're coming straight down. I think you're going to see declines across the country that are quite dramatic as we enter May. There's a couple of states that still are seeing sort of a plateau, maybe slight increases. If you look at Florida right now, cases are going up a little bit. Colorado, cases are going up a little bit. But those are states that are largely open. And, they're not seeing big surges. And there are states where B117 is now, that UK variant that's more contagious is now the most prevalent strain. And we're still not seeing the big upsurges. And I think that's the reality is that there's enough people who are vaccinated at this point. There's enough people who have immunity from prior infection that it's just a backstop against more aggressive spread. So we might see some persistent spread in certain parts of the country, but most parts of the country, I think cases are going to come down dramatically. And we'll have a relatively quiescent summer. I don't think that there's going to be a lot of COVID spraying this summer. Now, that said, we might never get below, 10,000 cases a day. We might get 5,000 to 10,000 cases a day through the summer because we're doing an awful lot of testing. We're doing much more testing than it's getting reported. So we're going to pick up cases, and there'll be outbreaks in summer camp. But I think as we look at the situation, those cases aren't going to represent as many hospitalizations. They're not going to represent as many deaths. We might still have some persistent infection, but we're not going to see, the death and disease that we've seen over the course of the last year as a result of the coronavirus infection that we're turning over. Just final point is, we're reporting, I haven't even looked at it more recently, but we're reporting about 1 million tests a day. We're doing a lot more than that because a lot of the tests that are being done now are antigen-based tests that are being done at home. They're being done in austere settings like schools and workplaces. And a lot of people are no longer reporting negative results. If they get a positive result, they'll go to a reference lab and get a definitive test. So the positive results get reported, but a lot of the negative results aren't getting reported right now. And the government sort of acknowledged this by acknowledging that there's a lot more antigen testing going on and it isn't getting captured. So what it really means is that our positivity rate across the nation is actually lower than what's being reported because we have more testing than what we're capturing.
A couple of things I want to touch on that you mentioned. By the way, Kathleen, I'm with you. I watch CBS every Sunday, Face the Nation, to get the truth from Dr. Gottlieb as well, and Margaret Brennan does a great job. You mentioned Michigan, and the one concerning thing I saw there was 70 kids hospitalized, I think last week, and that was more than twice they saw at the peak of COVID What concerns you about that number?
Well, a couple of things with Michigan. The epidemic there really started in the high schools when they opened their schools. And I'm not saying they shouldn't have opened their schools, but what happened was they had a population that was being largely sheltered from the virus all the way through. And when they reopened schools, they started to have spread in the schools. And that was an unvaccinated population. And also, they did it at a time when B117 was becoming epidemic there. B117 got in early in Michigan. And they did it at a time when it was still cold. They weren't getting any benefits of a seasonal change like the South was. So it was a very bad set of circumstances that created the conditions for the outbreak there. Kids are unvaccinated, and so they're still vulnerable to this. And we know that B117 is more contagious across the board. It's more contagious in adults. It's also more contagious in children. It's not more contagious in children relative to adults. It's just more contagious to everyone. So kids are vulnerable to it. I think that as we get more of the adult population vaccinated, we'll see infection levels come down in kids too, even on a relative basis. If you look at the data out of Israel, infection levels in 16 and below have really plummeted because as you control the infection in the adults, it really took away the reservoir of infection for kids as well. A lot of kids who get infected get it from adults. So I think that we'll see infection levels come down in children as we control the infection levels in the adults better. You know, unfortunately, we're probably not going to achieve the same vaccination rates that Israel or even the UK, for that matter, have achieved. But I think we'll do better than where we are right now. I think we'll get to 160 million Americans vaccinated, and then we'll start to slow down. And we're already seeing a slowdown in vaccinations, but we'll get another 25 million people vaccinated from where we are right now, and then it'll be a tougher slog. You know, because what's going to happen is a lot of the people who really want to be vaccinated will have been vaccinated. It'll be summertime, so people will say, you know what, I'll just wait to the fall. And infection levels will come down. So a lot of people who are sort of more marginal customers for the vaccine will say, well, there's not a lot of COVID now anyway, so there won't be sort of the impetus to go out and get vaccinated. So, you know, we'll get more people, but I don't think we'll get the same levels that Israel is getting.
But because of those people that will never get the vaccine, are we stuck with this thing potentially forever? I've seen the latest poll showed 34% of Republicans said they will not get it, and 30% of independents. So because of those people that are reluctant to get the vaccine for a variety of reasons, are we going to be stuck with this thing for a long time?
Yeah, look, I think that this virus is here to stay. I think in the near term, it's hard to tell what's going to happen in 10 years, but certainly, you know, next several years, this is going to become an endemic virus where it's just going to continue to circulate at a low level. And I think in the wintertime, it will circulate more aggressively, and we'll need to be more prudent about what we do in the wintertime. Coronaviruses are typically late winter pathogens. They'll circulate in January and February. So I think that this virus is going to be back, you know, in some fashion in the winter. We'll get vaccination rates up. More people will come back in the fall and the winter to get vaccinated. We'll start vaccinating the children. And a lot of people had it too. So even if we get new variants that pierce prior immunity and we start seeing reinfections, people will still have some residual immunity. Hopefully, we'll also get a drug that treats it, like a Tamiflu-like drug. Those are in development, including by Pfizer, the company I'm on the board of. So, you know, we might have a different armamentarium to deal with this. But yeah, this is going to be here, and it's going to spread at a low level. And I'll say, you know, we've been oddly complacent about the spread of respiratory diseases in the wintertime. We tolerate far too much death and disease from flu, from RSV, from all kinds of respiratory pathogens where we don't take simple precautions that could probably cut down on the spread of respiratory diseases in the wintertime. People go to work not feeling well. You know, people braved out a cold. That was the right thing to do, or perceived as the right thing to do. We need to change our behavior. We're not going to be able to be complacent about respiratory pathogens with a dangerous pathogen like this. So I think we're going to just be generally more careful in the wintertime. That means encouraging people to stay home when they don't feel well, or stay home and get tested when a family member doesn't feel well. It means looking for ways to de-densify offices in the middle of the wintertime, encourage flexible work schedules. I made a comment today on CNBC. You know, I don't think we're going to be cramming 30 people or 40 people into a room that holds 10 for a holiday party on December 20th. I just think we're going to do things differently. And that doesn't mean it's going to be a real drag on society. I think a lot of things will become, you know, commonplace, but we'll do things differently to reduce the risk. And the final point I'll make is, you know, if you look at the cumulative, setting aside the public health implications of influenza, if you look at the cumulative productivity hit from influenza each year, from flu spread, it's significant. It's a lot of money, lost money in terms of lost business. I think if we just implement simple precautions to try to control the risk of coronavirus in the wintertime, we're going to pick up the costs of that from much reduced incidence of flu. So for people who think that this is going to be a burden on society and it's going to be a big new cost, I think that there's going to be a potential upside as well, that we not just reduce the risk of coronavirus, but we'll also reduce the risk of flu. If you look at flu incidence this year, it plummeted because the mitigation that we used against coronavirus worked, okay against COVID, because COVID's a pathogen that spreads through aerosolization, so it spreads more easily. But for a pathogen that spreads probably primarily through aerosols like flu, it worked really well.
Would you feel comfortable, and you're a father of 3, sending your kids to sleepaway camp this summer? I know a lot of Westport parents are wondering that right now.
Yeah, I'll be sending my kids to camp this summer. I think kids are going to be back in camp this summer. Most of the camps seem to be taking reasonable precautions. Again, I think that the risk is going to be low this summer. I just don't think that there's going to be a lot of coronavirus. That doesn't exclude the possibility that you could have an outbreak in the camp. And I suspect we're going to see outbreaks in camps. But, at least it's probably tougher for a day camp where kids come and go. Sleepaway camp can create a protective bubble around the environment. But I think that the risks are sufficiently low. Activity outdoors are much lower. Frankly, I think CDC should be lifting the recommendations for wearing masks outdoors right now. This wasn't as much of an issue in the wintertime, but now that people want to go outdoors and we want to encourage people to take activities outdoors, the risk is sufficiently low. And, the other thing is our public health measures really need to be focused on trying to prevent spread to high-risk people and spread to large groups of people. We're not going to be able to prevent one person from infecting one person in an outdoor setting. We're just not going to be able to do it. And we shouldn't try to design public health measures to achieve that because the cost is going to be too great. What we really want to do is prevent outbreaks. And we want to make sure vulnerable people are protected so that, you don't spread to one person in a vulnerable setting where either someone can become seriously ill, like in a nursing home, or it could trigger a larger outbreak in that setting.
We saw numbers spike somewhat in Westport after spring break. Spring break was last week for most of the Westport schools. I think we saw 9 cases at Staples Monday, 5 on Wednesday, which were relatively shocking numbers considering we were at 0 and 1 most days and weeks. Is it still safe to travel, or was that just a blip that you expected following spring break?
No, you're going to expect it when people move around. It's probably also an artifact of the fact that people probably went and got tested around travel, so they turned over cases. I don't know the details of those cases. None of us do. But I suspect some of them were asymptomatic cases that got picked up because people, did testing around travel, did testing around seeing family members, and so you're going to pick it up. I suspect they're not all cases that resulted from travel.
JP Westport, again, another thank you. We appreciate your nonpartisan science-first approach. Gratitude from a fellow Westporter. They just continue to pour in, doctor, so that's really nice to see how people... So let's fast forward to next school year then. You're comfortable with summer camp. Will we be looking at masks next school year? Will we be looking at mandatory vaccinations? I know Yale was the first college out of the gate to say required vaccinations to come to campus next year. Would you like to see that? Will masks be a thing of the past?
Yeah, look, first of all, on the vaccinations, I think it's going to be very hard to mandate vaccinations. You see businesses struggling with this right now. And businesses are saying, well, we're not going to mandate it while it's under an emergency use authorization. Maybe when it's fully licensed, we will. I don't think that's really going to change the equation. I think that there is just a general trepidation about mandating these for a whole host of reasons. I mean, it's a relatively new vaccine to a lot of people, so people are uncertain about it. People seem to have oddly sort of defined how seriously they're going to take COVID along political lines, as you referenced. So I think it's going to take a couple of cycles before this becomes something that's routine enough that businesses and politicians feel comfortable mandating vaccine, as we do with flu vaccine in certain settings. I mean, healthcare settings mandate flu vaccination for their healthcare workers. In terms of where it gets mandated, I think it's going to be a local argument. I do think that at a local level, you may see local school boards debating whether or not they put in place mandates for vaccinations, maybe in high schools. I suspect for the most part, we don't start the school year that way. I think that maybe we end up adopting it in some places as if infection levels spread and we start seeing outbreaks in the schools. But I don't think we start the school year that way in most places. But, schools will have vaccine drives. They'll try to encourage kids to get vaccinated. The pediatricians, I think, are going to be very helpful. I suspect that pediatricians are going to try to get their populations, their patients vaccinated. As far as masks in schools, I could see a circumstance where we start the school year that way in some schools. This is going to be a very local decision. I don't think that states are going to impose this because we'll probably be coming off a summer where infection levels are relatively low. And so they're not going to preemptively implement ordinances that people have to wear masks. It could be something that some schools adopt at the outset as they see how the school year goes, or they just, don't. And if we start seeing infection levels rise, then you implement them. I suspect if we come off a summer where there's relatively low levels of coronavirus spreading, which I think is going to be the case, we're not just going to come back in September and all of a sudden this is going to become epidemic. What's going to happen is it takes a couple of months for this to build. And so you're really not going to see a situation where infection levels probably rise until you get into maybe November. That's kind of what happened this year. I mean, we came off a summer where there was quite a bit of infection in August. And, September and October weren't epidemic here in the U.S. It really wasn't until November that you started to see significant levels of spread. So that's probably what could happen this year. If we're going to see spread, it's going to be later in the fall, probably in the winter. So I don't think we start the school year that way, but hard to say for sure.
There is good news, as you mentioned earlier, about the vaccinations. I think we're over the 50% mark of U.S. adults who have had at least one shot. And I should mention, Scott is on board. Dr. Gottlieb is on the board at Pfizer. Two questions on the vaccines. One is, should people be worried if they had the J&J vaccine? I know you wrote in the Wall Street Journal that you think the FDA should have handled this and not the CDC, and maybe it wouldn't have been paused based on 6 cases out of more than 7 million people. And also on Pfizer, should everyone expect a third shot in the months ahead?
Yeah, there's going to be data on the third shot. So we're going to have more data on what is the degradation in the protection from vaccination over time. And there's going to be degradation. It's good. The protective levels offered by the vaccine will decline over time. They might not decline dramatically, but they will decline over time. And I think we ought to expect that. What we've seen, the best proxy for that is natural infection. And what you see is people who are infected with COVID have immunity from COVID, but that immunity declines over time. So the best study around this was the landmark study. It's a Danish study. And what they found was that after about 7 to 8 months, people who were 65 and over only had about 47% of the protection that they had at the outset. Now, overall, it was about 80%. So the population overall still had pretty good protection from COVID, but the older population didn't. It declined more rapidly in the older population. So you could see a circumstance where, ACIP, the advisory committee that advises CDC about vaccination, makes a recommendation in the fall that says, look, if you're 50 and over and have conditions that predict that you're more likely to have a bad outcome from COVID and you're more than 6 or 8 months out from being vaccinated, you should get a booster. There's going to be, I think, my guess is, and this is just a guess, there's going to be some recommendation like that where higher risk individuals who are a good ways out from their original vaccination, there'll be a recommendation that they get a booster going into the fall. And how we define that, where we draw that line, I'm not sure. I mean, the data is really going to guide that. But remember, the people who are most vulnerable to COVID will have been vaccinated a year ago. Who'd we vaccinate in December? We vaccinated nursing home patients, and then we vaccinated older individuals right after that. So the people who are most vulnerable to COVID will have vaccines that are the oldest. And so I think there's going to be an impetus to look closely at the data and see if those individuals need to be revaccinated heading into the winter, 2021, 2022 COVID season. And that doesn't mean everyone else won't be able to get a booster. I don't think it's going to be necessarily contraindicated, although I don't know. It depends on what the data shows, of course. But I don't know that the recommendation is going to be universal. It might just be around a certain cohort of people.
For good reason, there is adequate attention on the vulnerable population and the senior citizens. But I was shocked to see the number from the CDC and the lack of attention it received in the mainstream media that 78% of those hospitalized with COVID were either overweight or obese. Now, overweight might be a bit unrealistic, but 42% of our population is in fact obese in terms of adults. Has enough attention been given to that Could this have been a wasted opportunity to tell people to start living healthier lifestyles?
It's hard in the setting of a public health crisis to get people to change behaviors that, have contributed to increased health risks over the course of many years. I think, people recognize, looking at what happened with COVID, that there are a lot of factors in our society that set people up for bad outcomes from COVID that, don't relate purely to the disease itself, but other conditions of living. Certainly, comorbid conditions like obesity, like other things that, potentially can be mitigated with the right public health interventions. And also, some of the hardships that people face societally, the fact that people live in multi-generational homes, which set up conditions for spread, the fact that a lot of people work in jobs where they couldn't Zoom in, they had to show up, that they were put at risk at the jobs, that they didn't have the social equity to demand proper protective equipment or other measures that could have helped keep them safe at work. So there were a lot of, I think, challenges, societal challenges, public health challenges exposed by this, where we saw a disproportionate impact from this in certain segments of society.
I do want to get to some Westport questions, and I promise I will. Just a few more scientific questions. And I am the last guy in the world that likes to jump in on conspiracy theories, doctor. I do not look at Facebook. I do not spread fake news. But when I watched the 60 Minutes report about where, in fact, COVID came from, I was left with a lot of questions. Jamie Wetzel, who was an NSC member under Clinton and who works for WHO, he basically said the Chinese showed us what they wanted us to see. Are you convinced that COVID didn't escape from a lab? Because I admit, I am not.
No, I'm not convinced it didn't escape from a lab. Look, there were multiple labs in Wuhan working with coronaviruses. The Wuhan Institute of Virology, the WIV, had the largest, we know this is fact, but had the largest collection of coronaviruses. There was also a CDC, the Chinese CDC also had a lab in Wuhan that worked with coronaviruses. People, the WHO team that went in said there's no way it escaped from the lab because their practices and their high security, what's called a BSL-4 lab, are so good it couldn't possibly escape from those BSL-4 labs. Well, first of all, they looked at the BSL-4 labs now, not 12 months ago. Second of all, we know for a fact that China wasn't using their BSL-4 labs to experiment with coronaviruses because coronaviruses weren't perceived as a dangerous pathogen or as dangerous as requiring that kind of security. They were using the BSL-2 labs. We know that in the spring, I believe it was the spring of 2019, it was a little bit before that actually, there was an outbreak of a novel coronavirus in pangolins. This is all documented, that bore a lot of similarity to SARS-CoV-2. We know that Chinese labs started to evaluate that strain because that's what you do. That's what scientists do. You find a new pathogen, you evaluate it. We don't know for a fact that it went to the WIV, but it would have gone to the WIV. I mean, there's no reason why a novel coronavirus discovered in China wouldn't have been sent to the Chinese CDC and the WIV. So it's possible that those labs had them. And there's a difference between a lab accident, meaning that someone accidentally infected themselves while they were working with it and ended up being patient zero, and a deliberate release. I don't think most people believe that this was deliberately released or that it was engineered. I think that there's speculation and, speculation based on facts that this could have been either an accident in the lab or it could have been a strain that was brought into the lab, was tweaked to be able to replicate in the lab, because we know they were doing experiments in cell cultures, human cell cultures. We know they were infecting animals with coronaviruses to evaluate them as part of their research. We know that that's fact. That's been reported by Matt Pottinger, Deputy Director of the National Security Council under Trump. That could have allowed the virus to sort of evolve in ways that made it more adaptable to human cells. If you were trying to adapt a virus to grow in human cell cultures in a laboratory and trying to adapt it so that you can infect animals as a way to evaluate it, you might change the characteristics of the virus in a way that could also make it more contagious, more likely to infect people. So we know all those things are true. Now, what we don't know is whether or not patient zero was someone in and around one of these labs, and we might never know that. And the other possibility is that there wasn't a single introduction. There could have been multiple introductions. The lab could have been a place not where it originated, but perhaps where a smoldering, epidemic advanced. So if you had an outbreak in animals in an animal reservoir of a novel coronavirus, it could have infected some people that way, and then maybe as it was brought into the lab, it infected some more people, and you had enough people running around with it at that point that the epidemic became inevitable. So I don't think we're ever going to know an answer to this question. Wow. I think if there was evidence that helped reveal this, it's probably gone. The best we're going to probably do over time is maybe get more details that help us date the initial introduction of the virus. And so there's now pretty good evidence that the first cases emerged in early December into the healthcare setting. So if the first cases were diagnosed in early December, that means the first infections were happening some point in November. So you start walking it backwards, and that could be an important detail. But I don't think we'll ever have a definitive answer to this question.
That is fascinating. Okay, one last science question. It gets back to your time as FDA Commissioner. Your work doing away with flavored vapes, I think, is one thing that we forget now, how dramatic that was. And it seems to have, let me just ask you, how successful was that? Because I don't hear about vaping as much as I used to. I don't see vaping. My kids don't talk about it. It seems to have been a massively successful move you made there at the FDA.
Well, use of vaping products by children is way down. It's probably a combination of some of the policy changes that were put in place, and it's also probably a function of COVID. Kids were home, under closer supervision of the parents. I don't think people were starting a habit that required them to inhale something as a deadly respiratory pathogen was spreading. So I think that there was other reasons, but certainly you started to see the declines in vaping use before COVID struck. And so I think COVID probably accelerated some trends that were underway. Hopefully they hold. Kids still get addicted to nicotine. I think that there's still things we can do to try to reduce the attractiveness of tobacco products to kids, and particularly combustible tobacco products. And the biggest remaining feature is the characterizing flavors in combustible tobacco. We moved to do it. It got hung up, banned menthol in cigarettes, and banned sweet flavors in the cigarillos, the characterizing flavors in the cigarillos, which Congress intended to ban, and tobacco companies put flavors in those things by calling them cigars and not cigarettes. But that's the unfinished business. I suspect the current administration is going to finish that, and they'll ban the flavors in the combustible tobacco as well.
And I understand the current administration might follow your guidelines in lowering the level of nicotine in cigarettes, which would be great. All right, let's talk about, a lot of these folks are from Westport. I don't know, how long have you lived in Westport? What brought you to this wonderful town? And what made you stay as well?
We've been here about a little over 10 years. And we initially were coming here just on weekends and in the summertime, and fell in love with the town. I mean, just the combination.
From where?
New York City, like a lot of other people. We made friends here. Love the fact that it has a small town feel, and you're right near the beach. You have proximity to New York. Just perfect, perfect aggregation of features. I remember being on a plane, actually. It was years ago with Lieberman, Senator Lieberman, and was talking to him. I was sitting next to him and did what you do on a plane, annoyed the person next to you when he probably didn't want to talk to me. And
now he would.
Westport, and he just paused and he goes, Westport, that's the best place in the world. It really does feel that way.
All right, so give me some of your favorite places. Is there some favorite restaurants or routines, or is there a walk you love, or what's your thing? Give me a day in the life if you didn't have to be on national television 7 times a day.
So when I was in FDA, I was commuting down. So I'd leave early in the morning on Monday. I'd leave my house around 4:30, 4:15. I'd catch the 6:30 shuttle, and then land at Washington National, go straight to work, straight to the FDA. And then work down there all week, and then come back on Friday. And, my family stayed back here. And so every Friday night, just about every Friday night, I'd meet my wife out at Oko. So I'd take probably, 6 o'clock shuttle back. Sometimes I can catch the 5. Usually I take the 6. Fridays. So FDA is located in White Oak, Maryland. And I stayed at White Oak, Maryland as much as I could because I didn't want to be in Washington. So
Who does?
it was convenient being 40 minutes outside the city. It's probably only 15 miles, but being there 40 minutes, every time the White House called me or the department and they said, you got to come down for a meeting, I'd be able to say, well, I could be there, but it'll take me 2 hours in traffic. And then they'd say the meeting's going to be over. Forget it. We don't need you. So that kept me distanced. But Fridays, I would make my sort of Washington day. So I would meet with the secretary and the deputy secretary on Fridays. I'd probably take a few meetings at the White House. I'd get my national security briefings on Fridays. So I did all my downtown work on Friday, and then I'd be able to catch the flight out of Washington National Friday night. And when I'd land, I'd go straight to Oco. And we'd have dinner every Friday night at Oco. We became a fixture, 2 seats at the bar every Friday night. I'm looking forward to doing that again, going into a crowded restaurant and being far too close to people.
Do you go out of restaurants right now inside?
Right now, no. So now, I've eaten out, and I've eaten out in the wintertime, but we've only eaten out outdoors. So we were at Match this week. We were outside. We've been at the Welk a bunch of times recently. I'm going to go to a Rezo this weekend, but all outside. I guess it was a little crazy when it was really cold out, but we had blankets and we put heaters on. But I like eating outdoors. We used to do it as much as we could even before the pandemic, and so the risk reward of going into a crowded restaurant right now doesn't really feel like it's worth it for me, given the fact that I like eating outdoors anyway. But I think that as the risk goes down, I'm going to be far more comfortable with it.
Okay, so are you like Fauci, 9 masks on, or is that silly? Should we have multiple layers? I know my Broncos mask is probably useless. I know it's not keeping me safe, but it looks good, right?
No, this is the advice. This is the advice I have on masks. First of all, you're talking to the wrong person, because if I could have worn masks 2 years ago in an airport or on a plane, I would have. The only reason I didn't is because I thought that I'd look silly.
You would have.
But yeah, in flu season, I was the guy carrying around Purell all the time. So I'm the wrong person.
You should have invested.
That I'll just say up front. I'm not the normal. But the cloth masks are going to protect other people from you. The reason why, and I was part of the effort to try to get a recommendation on mask wearing early back in April, and wrote it into a report that I put out. And I was having discussions with the task force about why they weren't issuing it. And the data, we put together quite a bit of good data, I think, about masks. What was available at the time. There's much more now. A good cloth mask is going to prevent the risk that you could spread the infection to someone else. And so the view was that if a lot of the virus is spread is through asymptomatic transmission, and particularly young people who don't feel sick, but they have the virus and they're going out, if we can't keep them from going out, let's tell everyone they should wear masks, and it's going to cut down their risk of spreading the virus. But we knew, and we said at the time, if you go back and look, wearing a cloth mask, it affords you some protection, but it doesn't afford you a lot of protection. It cuts down on your respiratory droplets and cuts down on the risk that someone gets infected from you. It's not going to dramatically reduce the risk that you get infected. So a cloth mask is about 20% protective, a good cloth mask. If you wear a level 3 procedure mask, like a good surgical mask,
like this,
that's about 60%. That's a KN95 mask. The other one you had on was a procedure mask.
Yes.
So that's an KN95 mask. You had another one on.
Yeah, and that's what my kids wear.
Yeah, so that's going to give you a good level 3, and it has to be a level 3 procedure mask. So a lot of them are level 1 and level 2. A level 3 will give you about 60% protection from getting infected. An N95 mask or a KN95 mask will give you 95% protection. So if you want to up the protective value of a cloth mask, put a procedure mask underneath it, like the one you have. If you really want to protect yourself, wear an N95 mask. They're available now, so you can get them. Right now, I think you need them, less than you did before. But, the question is, are you wearing a mask to protect other people from you? Or are you wearing a mask because you want to also protect yourself from other people? And if you want to protect yourself from other people, the quality of the mask really matters. And you're going to get a much higher level of protection from a higher quality mask. My view is, if you're already bothering to wear the mask, they're all equally uncomfortable. Try to wear the best mask that you can source to give yourself the maximal level of protection. So that's generally how I break down the masks. Now, frankly, I think we probably should be, and the governor's doing it here in Connecticut, lifting the outdoor mask mandate. I think we should be doing it now, encouraging people to move outside.
You happy the way the governor has handled the reopening? I know May 19th, everything, we basically go back to some sense of normalcy. Has he done a good job? And
I think the governor's done a very good job in this state. I think he's struck a careful balance. Implemented mitigation when we should have. I think he left as much business activity as possible. He prioritized the right things, getting the schools reopened, getting kids back in school, put a lot of focus there. I think he, tried to emphasize as much as possible the mitigation that was the least burdensome on us economically and socially, like mask wearing. Masks were the last thing to go. He left the restaurants open, but didn't let them turn into bars. I think that there was a lot of careful judgment where we sort of, carved the right middle path. We didn't do as stringent mitigation as we could have, but we took the precautions that were the most obvious ones. And so I think the results are good in this state. You've got to look. The early experience with COVID, the Northeast was the first to get infected with COVID and had a very hard experience because it was a time when we didn't know what we were doing. Nobody did. We didn't know how to treat it. We didn't know how to diagnose it. And so New York, New Jersey, Connecticut will always look bad relative to the other states when you look at the statistics because they were hit the first. Back in the spring, we were treating COVID with Pepsid and hydroxychloroquine. We didn't know how to treat it. And once we figured out how to treat it better and we got into the summertime, mortality was cut in half as we got better at treating COVID. So the experience here was very hard. But I think, overall, Connecticut did a good job. And the news out tonight from Yale, there's a lab there, Nathan Gruber, I think his last name is, who does sequencing work looking at the strains that are spreading here in Connecticut. It looks like B117 is becoming the most prevalent strain. So it's about 60% of infections, not that New York variant, that 1526 New York variant. And, believe it or not, that's probably good news because B117 will probably crowd out the other variants and probably on the whole is a little less dangerous than some of those other variants because you're less likely to get reinfected with B117 and the vaccines cover it very well. So if the most prevalent strain becomes a strain that's covered well by the vaccines and where people who've previously been infected are less likely to get reinfected, on the whole, that probably bodes well for the future, meaning that, you're unlikely to see new outbreaks with sort of scary new variants.
So you can't help get back to the science. So that was your fault. So I was going to ask you this because we're going to wrap this up, I promise. But you mentioned bars. I want to know when Scott Gottlieb and I, Dr. Gottlieb, get out and get a drink in Westport, what are we having? Like, what's your go-to?
I'm not that fancy. I like the
beer
drinks.
Guy, wine guy, cocktail, tequila, bourbon.
I like the drinks at the Welk. So I figured out part of my pandemic preparedness was figuring out how to mix a Frogger.
A Frogger? I don't know the Frogger.
That's one of the Welk drinks. Yeah.
I'm gonna have to ask Bill how to make that. All right, last question, and if you don't have an answer, that's okay. I should have told you this is coming. Who else would you like to see interviewed? It could be Westport, it could be Darien, New Canaan, Greenwich, and it could be media, sports, it could be politics, it could be Hollywood. We have all sorts of interesting people in Fairfield County.
So my wife is on the board of Homes with Hope and helps run the homeless shelter here in Westport. So I would nominate her.
That's a good answer. We all support Homes with Hope. They do great stuff in Westport. If you folks don't know it, please check it out. Dr. Scott Gottlieb, former FDA commissioner, and by the way, a cancer survivor. I mean, and the most trusted voice in COVID in this country, as far as I'm concerned, and clearly everybody in this conversation as well. It's been a real pleasure. Next time, we'll have a Frogger.
Sounds good. Thanks a lot.
Thanks, Scott. Appreciate your time. Dr. Scott Gottlieb joining us today. Have a great weekend, everybody. It's a pleasure that you've all joined us here on Connecting Connecticut.